Now people like to use the term of so-called innovation. But in my opinion, someone who is qualified to innovate is that someone who already know better than the other people. Otherwise, if you only learn functioning muscle, you only do 3 cases, and then the 4th case, you change it a little bit, and then you call innovation. Innovation should be very carefully done, always.
Welcome to The Deep End, a plastic surgery podcast where we explore the people and ideas shaping the future of surgery. Today, we're honored to speak with Professor Fu-Chan Wei, a legend in reconstructive microsurgery and one of the most influential plastic surgeons globally, best known for refining and popularizing the vascularized fibula flap for jaw reconstruction. Professor Wei transformed Chang Memorial Hospital in Taiwan into a world-renowned microsurgical center. Beyond his pioneering surgical techniques, Professor Wei is a distinguished academic leader, having authored over 500 peer-reviewed publications and textbook chapters. He has lectured internationally, sharing insights that have shaped the field and trained hundreds of microsurgeons who now lead programs worldwide. Join us to discuss Professor Wei's extraordinary journey, groundbreaking contributions, and visionary perspective on the future of microsurgery. Let's dive in.
Welcome to the Deep End podcast. We're honored to welcome a true giant in the world of reconstructive surgery and just plastic surgery and medicine and beyond. Professor Fu-Chan Wei, a pioneering force in plastic surgery, microsurgery from Chang in Taiwan, with a career that has redefined what's possible in reconstructive medicine. He's led groundbreaking advancements from free flap surgery to complex head and neck reconstruction and super microsurgery. And your innovative techniques have not only saved lives, but have restored quality of life in countless patients. And truly, when we say this, across the globe. So you're a teacher, you're a trailblazer, you're an inspiration to Hank and I and to everyone else listening. And we had numerous people ask us to get you as a guest. So we're thrilled to have you here on the Deep End podcast. Of course. Well, that's the introduction doesn't do it justice. You really deserve a whole podcast in itself just introducing you. But one of the things that Hank and I are usually interested in when doing these podcasts is getting a little bit of a background as to how did you get to where you are? Like, what inspired you to pursue medicine in general and specifically microsurgery and plastic surgery?
Be honest. When I joined the Department of Plastic Surgery, that was in the late 90s, that's the century. And our medical center was relatively new, only a couple of years, and our department is new. At that time, we have only 2 attending staff. And one is Dr. Noordhoff, who is quite well known for the credit palate and other contribution to Taiwan, because Taiwan at that time was relatively underdeveloped. And then we have another one also hired by Dr. Noordhoff, and they were doing basically, all kinds of plastic surgery. So at that time, there's no resident, a program that's kind of structure. So when I finished my 5 years of general surgery training, because I admire Dr. Noordhoff very much, so I decided to follow footsteps. Then I went to him, said that I want to become a plastic surgeon. And then after 1 year, he said to me, Fu-Chan Wei, I have nothing to teach you, because you have learned everything here. And he want me to send me to somewhere to learn something new. Somewhere to learn something new and bring it back to our medical center so that I can serve people in Taiwan. And he has no idea because he was a missionary. And he came to Taiwan. The main purpose is to serve as a missionary. And he himself, did not have a complete plastic surgery training. So when he came to Taiwan, he saw so many patients that require, the surgery. And one of them is the credit palate patient. So he then established credit palate, and he, provided service just by his general surgery knowledge. Actually, at that time, there's no, training yet. And of course, later on, he realized this is not adequate. So he returned back to America for 2 years of plastic surgery training in Michigan, in Grand Rapids. And it's the same kind of background when he teach me and when he taught me, and he said, I have nothing to teach you anymore. So how about you go somewhere to learn something new? So, and because at that time, there's no much connection between him and, the medical center in America. So the center that he got to know is University of Toronto. So he said, Fu-Chan, how about I send you to Toronto, and then you go there to learn something we don't have here and put it in the bag. So this is how I was sent to there. There's no special, assignment to me.
Mm-hmm.
And when I was in Toronto the first month, because I didn't speak English that much, very little. So I always tried to talk less. But I found that I was interested in many things, including laser, treatment and credit palate and many other kinds. And that after 1 month, the chairman, Dr. Lindsay, found that there's a guy from Asia who is quiet and not ask a question, but he showed enthusiasm in learning everything. So then one afternoon, he invited me to have a cup of coffee with him. And he said to me, and then after chatting, he said, hey, Fu-Chan, what did you like most? I would suggest that you focus on one thing. Mm-hmm. And the same kind of worry that I want to not to talk too much just because of the English limitation. It's happened that about 1 week ago, I was involved in a replantation. Mm-hmm. It's a some avulsion. And we have tried revascularization for so many times. I forgot how many times. It's maybe 5-6 times. And finally we succeed. And at that time, it's in the beginning. So the reason they enjoy seeing an enthusiastic, a fellow. And so they all find excuse to leave at some point. So I show my enthusiasm, and then actually I help the entire procedures. And then because of that memory come to my mind, so I said without thinking, but it's not true from my mind. I said, I'm interested in microsurgery.
Yep.
And then Professor Lindsay said, that's great. Because we, Toronto, is one of the early center doing microsurgery. We have 3, a very good staff. And one is Dr. Mentorship, one is Dr. Zucker, and the other one is Nancy McKee. And he said that, tomorrow I will, introduce you to Dr. Mentorship. And then this is how I become an interest in microsurgery. So it's just by accident. And there I learned a lot from them, especially how to do a detailed pre-operative discussion, before they start the surgery. So this is something I still feel very useful for myself. Maybe this time I can teach people how to do not only the microsurgery, how to plan and how to give the reasoning why you choose this. And I have a very, very good grasp of all those literature in my mind. So I'm able to, to tell my resident fellow how to select, good article to read and how to give your critique to them. So this is what I learned from them most. And of course, at that time, there are not many cases, from my point of view at this time. Because in 1 year time, I was scrubbed only in about 40 cases of microsurgery. That is a small number, it's even 2 weeks, here, now we are practicing. But with that already built my foundation for the microsurgery. So this is how I become, reconstructive microsurgeon. It's by accident. It's not I make up my mind from the very beginning. Yeah. But when I come back to Taiwan, in Asia, usually you respect your teacher. I always say that as my teacher, Dr. Noordhoff, has a good vision. He sent me to learn something important. I always say that, but be honest, it's not the truth. So this is how I become interested.
That's incredible. So I'm an intern, so I'm in the very beginning of my, surgical career and plastic surgery career. And I'm just so honored to be able to sit across from someone like you and be able to ask you questions and learn from you. But one of the main things I'd like to ask is, you're so well known internationally. You've trained countless surgeons worldwide. You've gone to visit other surgeons that are top in their field. And so you have so much wisdom in surgery in general. I'm curious, what do you think makes a great surgeon in addition or beyond just, technical skill?
When you start a career, in the earlier days, usually you are more concerned about the technique. And then gradually you may expand to other things. But at this, after more than 40, it's almost 45 years, practice in reconstructive microsurgery, then I realized actually it's just like the most advanced course, for microsurgery is that you do a very, very good preoperative, everything okay, very good preoperative discussion. And then in that discussion, the resident fellow should prepare the history or the workup, make sure they are updated, make sure they're not missing anything. But now I can see, I think in most part of the world, the surgeons are very busy, and they maybe prescribe some examination, but in that the day before surgery, everyone may not able to go over all of this information. So therefore, it's sometimes into the OR, you find that the patient is using, anticoagulant. This happens from time to time. So I think with this in mind, then I consider the patient safety. You have to make sure that all the workup is adequate. And the reason is able to give the interpretation to all the image study. Otherwise, we depend very much on other, specialty, and we're not able to read ourselves. It's a pity. And then the second part of this, then I just encourage the resident and the fellow to present their suggestion. For example, we are in reconstructive surgery in head and neck mandate, I myself, at this time. So for a case of mandibular defect associated with soft tissue defect, then there are several options, including the reconstruction plate and soft tissue, flap, or include a bony reconstruction with the vascularized bone. And they have the advantage and disadvantage in individual case. So at this time, the resident fellow should come up with the idea, what they think should be the option one and what should be the option two. And then they should give the reason, which is supported by the third part. The third part is a brief literature review. And many times the reason may not be able to pick up the right literature to review. They may have something out of date. out from somewhere there's nobody knows about, and the quality are really poor. You can see that, but they may not know they are not taught. They may not know. So after that discussion, then we together make a decision that, of course, as a responsible surgeon, I will say that I prefer option one, and I give my reason. And they all agree. If they all agree, then we will choose this. So this is for patient safety and for streamlining, the surgery. And then after that, then I say that this is a case in the central segment of the mandible defect. It's a little bit complicated. But however, the reason has been with me for 2 months, and he is able to harvest the fibula. So how about I allow you to harvest the fibula? And then when you finish that, I will come to do osteotomy and osteosynthesis. And then afterwards, I will give because it's a primary neck, so I will give the opportunity to the fellow. The fellow has been here for 9 months to do microanastomosis. So with this kind of assignment, everyone know what they are going to do.
Yeah.
They have basic. So I think this is the very important part in my mind at this time. But usually when they start, they like to do microanastomosis. That is the most, straightforward part.
Yes.
So
agreed.
Thank you.
And it's, you bring up so many great points. Like we're all so busy. Just taking, that time at the beginning of a case to not only educate, but to ensure patient safety is absolutely critical. And I know I've heard you talk, and the emphasis you place on that is so important. But on another question, you mentioned fibula. So now I have to ask, because we're interviewing Professor Fu-Chan Wei. You are an innovator. You're the definition of an innovator, a pioneer. And, when I think of osteocutaneous free fibula, I think of you. Out of all of your experiences, innovations, techniques, what do you think you're most proud of?
It seems you have mentioned about the fibula. Let me, just very honestly, tell you that what I feel that I have contributed. Actually, the vascular fibula has been explored from middle 70 by Ian Taylor, by Chen Zhongwei of China, by many in America and other countries. But at that time, they only know that the blood supply of the fibula is from the peroneal vessels. And in case they need to reconstruct the soft tissue coverage at the same time, they found that the skin they can harvest together with the fibula are unreliable. And you can imagine, if it's not reliable, then the indication of fibula for the complicated reconstruction, such as the lower extremity, you may not be able to fulfill the goal of reconstruction. So at that time, I did a study, then that showing the blood supply to the lateral aspect of the leg can also come from branch of the fibula. And through that, I think I not greatly expand the scope of its application. But I have done that since 1983. And the first time I present that in American Society Plastic Surgery in 1984. And I finally published in 1986. So I use that for long bone reconstruction, compound long bone defect with the skin and with the bone and without inclusion of the muscle. So the vessels come in the septum, through the septum, from the peroneal artery, through the posterior crural septum to the skin. If you're able to identify that from the very beginning, that the skin pedal, usually very reliable. Unless that you have very extensive big one, then sometimes you may have some margin necrosis. So this greatly expand its clinical application. And in 1989, you may remember David Hidalgo. He published that in the July issue of PRS. At that time, I was visiting professor in Penn State, Hershey. And they have a journal meeting. They invite me to join. And then at that time meeting, I got chance to read that article. It just come out, July issues. And the last sentence of his abstract, in this paper, the mandibular reconstruction with fibula was the very first one and very well described by David Hidalgo. I like to say almost 90%, all the detail being described by him. It's a wonderful paper. I enjoy reading it. But I also found there's an opportunity for me because in the last sentence, he said that the skin pedal is not reliable. Although I have already published that several years ago, but obviously he did not get a chance to see it. So this implies that the relationship, encourage them to read more literature. Otherwise, they may say something that they innovated, but actually turned out has been there for a long time. So because of that, so you can see that the expansion of the fibula for not only the long bone, but also for jaw reconstruction. I think I consider that is my contribution. But I cannot say that I invent, the vascular fibula is unfair to the pioneer. But I was the first one that, ensure people that if you find the septal vessels, the skin pedal on the lateral aspect of the leg can be harvested reliably with the vascular fibula bone for simultaneous reconstruction of bony and the coverage defect. So this is, I consider, maybe my contribution.
Yeah. One of your many contributions. And what I want to talk about next is Chang Memorial Hospital. It's world renowned, but why do you think it's become, so world renowned, and what makes, their surgical training and their clinical outcomes so exceptional? Is it the culture that you've built there and just talk a little bit about that.
Thank you very much for your compliment to our division. Actually, when I returned to Taiwan in early 1981, and at that time, Taiwan was in a rapid industrialization stage. So, when the country in rapid industrialization, the industrial safety system, was not that well established. So you can imagine that with this kind of situation, the hand injury must be quite many. And also, the people at that time only afford to ride the motorbike. And motorbike may cause, not only head injury, but also the lower extremity trauma. And those two areas happen to be the good application for reconstructive microsurgery, because that is missing tissue. When you really in a missing tissue, then you need to transfer from somewhere to replace that missing tissue. So this is the first reason. So we happen to be in the right time. And the second, I'm working in Chang. This is the biggest hospital at this time, in Taiwan, and I believe in the world maybe as well. And here we have a total of 10 hospitals. It's a conglomerate for the whole Taiwan. And the one I'm working was the original one and have the bed about 4,000. So you can imagine the capacity and drawing and the medical system I will mention later. And so at that time, it was a in the beginning, so all the pioneer of the hospital very motivated. They really want to make the hospital a good one, so they work hard. And then the third, a good condition is that at that time we had the so-called labor insurance. It's not covering the whole nation, but at least the working people is covered. So if the surgeon willing to spend time, have the knowledge, have the skill, they can help the patient without worry about the money, the financial issues. So we happen to be that. And then in the beginning, although it's only myself, the first year, the second year, but the third year, from the third year, fourth year, I have very talented and very enthusiastic people join me, who are like David Zhuang, who is world famous for brachial plexus functional muscle, and Hongji Chen, who is famous for many things, especially about the so-called esophageal reconstruction. At the same time, is able to produce voice. So it's called voice tube. So with three, all hardworking guys, and very, very often at the midnight, 1 o'clock, 2 o'clock, then we have, three people in 3 rooms. So because of that, we quickly, accumulate enough experience. And then at that time, we're still not quite sure that what is the quality of our cases compared with the quality of other, centers. And until the first time, it's 1983, 84, I happened to have a chance to join Asian Congress of Surgery. There was a microsurgical section, and I was one of the panel. And together with those 3 who I admire very much, one is from Hong Kong, and the other one from Singapore, the other one from Thai, I forgot. And then after that panel discussion, just I feel that it seems that my material not only better in quality, but also, larger in number. But I, keep low profile. I'm humble, and because I'm not quite sure what I feel is correct or not correct. And so therefore, at that time, I was very enthusiastic. Almost every, local, regional, in Asia or international meeting, I try to attend. And with the intention to compare with the others and to be able to meet those that whom I admire and then talk to them. And then after so many times, maybe 6, 7 times, then I feel confident that my material not inferior.
Yeah.
So because of that, it really encouraged me to continue to pursue, another level of the service.
That makes a lot of sense. We were just talking about Chang, what makes it so special, and really, oftentimes it's not quite clear when you're the one inside the hospital until you are able to witness what's happening at other institutions, at other medical centers around the world or in your part of the world, until you actually recognize that you're doing something special. And I've been able to cross paths with a lot of people who've trained at your institution, and I've been incredibly impressed by their surgical technique, but also just their patient care, their humility, and just wonderful people from I could name countless ones. But one question that I had for you is, part of what makes you so special is your emphasis on education and training the next generation. What do you think is the most valuable lesson, or perhaps regret, or something that you can impart on a fellow or a resident if you're going to offer them any advice, just, a word or two of advice that you'd tell another resident or another fellow who's training and hoping to be a big person like you in microsurgery?
Thank you very much. Please allow me to elaborate a little bit about what I just, explained, because I know there are many centers that
Yes.
have very, very good talented people, but they may not be able to develop, such kind of comprehensive cancer center, which can cover almost all kinds of microsurgery. This is something I really like to share.
Absolutely.
It's a private hospital. I'm working. Chang is a private hospital. So the chairman of the board is able to make decision by himself. And he is a very, very smart guy. So in 1988, when I talked to him, I need to have a microsurgical intensive care unit, because the ICU usually, when you put your patient there, it's not life-threatening. In the earlier days, it's only involved the extremity, not to the head and neck yet. So they may not take good care of our patient. Instead, they may pay more attention to the heart surgery, to the lung surgery, to the abdominal surgery cases. So because of that, I feel that I need to have my own intensive care unit. So I went to talk to him, and he agreed. And he asked me how many beds I need. I initially say 8 beds. And he asked me, is that enough? And then I said 12. And he said, is that enough? And then I feel, just very, very surprised. I said 24. He said, this is good number. This is good number. I just don't know how he just, because he is a icon in industry, not in medical profession. So because of that, he gave me everything, almost everything I have. This is number, another. And the other one is that, I happen to be lucky. I choose all the talent and good people.
Mm-hmm.
They join me. Then I was thinking how to make them feel proud.
Yeah.
So at that time, I start to think. And I think that if everyone overlap doing everything, then I think the credit may all come to me. So this is the reason why, in some good center, they're not able to keep 2, 3 very, very smart surgeons under the same roof. So we decided that I want to do more on lower and upper extremity. I think that was 80. And then David, he returned after training with Julia Turtis. Then want him to specialize in brachioplexus. And at the same time, I also stopped doing, functioning muscle transfer, although I feel pity, because that is something I really learned from Dr. Mentor and Zucker. But I still want to give up to that. And when I give it up, I never come back to repeat their work. Mm-hmm. And then Hong Chi-Chen at the time, we have many, corrosive esophagitis cases, because at that time it's a misswallow and something. So he's so good. So we decided that I'm not going to do that. How about just, you do it? And this is the super specialized turned out to be very successful for two things. One is that you can accumulate enough experience in short period of time. And with the quantity you have, then you can improve your quality. So quantity is the mother of quality. And the second is that, because when patients come to me, say that they have brachioplexus, then I always say, oh, we have very, very good one, much better than mine. And then David is the one. Then I refer to that. And they also did the same things to me. So because of that, everyone is able to accumulate enough experience. So come to the conference, go to the conference or come to the consultation, we always, give this kind of credit to the due person. So maybe because of this, I'm able to keep the people, very talented people, many of them, in my department for a long time. That is the foundation for the steady development of the department. Mm-hmm. So maybe this is useful. Hopefully that you agree with me. This is an important foundation for. And then why we start to train people, we start from 1986. At that time, we have American fellows, and it's not at that time. It's not because we have the reputation. It's because Dr. Noordhoff is from America, so people come to learn, credit palette from him. They saw that the microsurgery, interested. So they apply. So my first one is from Grand Rapids. Mm-hmm. And the second one at the next year, 1987, is from Philippines. And at that time, my thought is that because without Dr. Noordhoff, he was in Taiwan for 40 years. Without his contribution and without learning all those, especially from other countries, because after mine, there are many from our department, they all go somewhere to learn craniofacial, to learn burn, or to learn whatever, come back. Feel that this is the time that we should return to the international society. Especially we notice that microsurgery, the clinical application is so wide and so important. And there are only few centers that are really good, and able to provide very large volume hand-on experience. But without large volume, every single case after surgery, doing the surgery, you feel, how do you say that? Not comfortable. So I now always convince my fellows, because of the number we have, say that in 1 year, if you follow my timetable, and you're not only able to learn to do the microsurgery independently, you're able to do it in comfortable manner. So I think I have proved this in most of the cases. Of course, there are sometimes exceptional, because of the, when we accept the fellows, we not only consider that their capability, their performance, but we also consider humanitarian.
Yes.
Somewhere they have earthquake, they don't have anyone, then we like to select them. They're not finished their training yet. So because of that, but basically we have more from America, from North America, and from Europe. They're all doing very well. Yeah. To those from South America, they more than half also doing very well.
Wow.
But from less developed country, that is depend very much on how the support they gain from their institution. So it's also an important consideration.
Absolutely.
Thank you very much for allowing me to add those, because I think that many people are curious about how come we can develop and so well and train so many people. In fact, we have, if we count the 1 year as a fellow, usually I only consider those longer than 1 year as a fellow, and the others, they are visitors. So we have almost 190, people studying.
Wow, that's amazing.
Wow.
Right. Yeah. And for those that they come for short term, and now I limited them not longer than 3 months, because I want to make a distinction between fellowship and observer. Yeah. The observer, they at this time, because too many, so we do not allow them to scrub, but they can join any activities, and the maximum is 3 months. And this is what I learned from Louisville, Kentucky. So try to so that the good opportunity would not be taken away by the aggressive visitor. I mean, so make sure that our resident get good training and our official fellow got adequate training. So because of that, maybe, and also because we train them, the so-called all-round microsurgeon. Mm-hmm. Our microsurgical department divided into 4 divisions. One is head and neck. The second one is breast and lymphedema. The third one is trauma-related, basically hand and lower extremity. And the fourth one is peripheral nerve-related, including brachial plexus and functioning muscle. So all the plastic surgery background, that resident, they come to us, they have to rotate through all of this.
That's amazing. It's the full body. It's every section of microsurgery. As someone who's been on the forefront and the leading edge of microsurgery your whole career, and you've had a lot of foresight, I'm curious what you think the next big thing in microsurgery is, or what's the future of microsurgery?
I think that the future of the microsurgery shall be bright, but we plastic surgeons and gradually lost our territory. And we always complain that the other specialty like otolaryngology, head and neck, and oromaxillofacial, they take away opportunity from us. But I like to say it's we give up. It's not they take away from us, because the cases are so many. When I begin this, you have difficulty. But my mom asked me, hey, what is microsurgery? I say, this is this. And he say, how can you have patient? It just, the person don't know the potential there. Mm-hmm. But when you're able to master the skill and then the organization, then you will find there are many, many potential applications. Unlimited, I like to say. But you see, if you look at, this is what Scott Levin talked to me several times. Scott say that, the enthusiasm, decreased in America. And I say, wow, no, it's not. I see its enthusiasm rising. And he remind me, if you exclude those, that they use that for DIEP for breast, then I realize it's not that many. Like in early 2000, I always, 25 years ago, or late, 1990, I always invited by otolaryngology, head and neck, to do, the workshop, how to do this, how to do that. It's only 25 years. And you see that they take over. They exceed us. And because we didn't make ourselves available when they finish. But this is something I like to share with you and the other audience, is that because in that time, the concept of perforated flap and the technique still not developed. So all the donor side, is either in abdomen, so-called rectus abdominis, or in the back, scapula or latissimus dorsi. So when the excisional team, especially the head and neck team, they finish about early evening. They give to you. You have to turn the patient. Yeah. And then you have to harvest and you have to turn the patient again. So usually you go home, most of the time after midnight, 2, 3 o'clock, very common, even in the early morning. But the early morning, you have another activities. So because of that, I start to think that if we're able to do two team, although it's now in many centers considered as a routine. But if you trace back, I think I have made some humble contribution to that. because I transfer the iliac to fibula. And I transfer all the latissimus dorsi, forearm, and rectus abdominis to anterior dorsal and to pop flap, and all are from the lower extremity. So because of that, when the excisional team doing their surgery, we already start to do the flap harvest. I think now in many centers this is routine, but because the young generation, they didn't know how difficult we were, and also my humble contribution. Someday people say, Fu-Chan, what's your major contribution? I will say that I make, microsurgery easier and sustainable, because you can go home to have dinner with your family. Otherwise, you cannot continue for a long time. So this is really something important, and I feel that I really like to share this with audience. Thank you very much.
It's extremely important. I mean, I'm a microsurgeon. I have 3 daughters. You're going to have a 4th. And I like to make it home for dinner, and I like to take good care of my patients. But the way that, thanks to you and all the leaders in microsurgery, allowing us to learn how to make it reliable, efficient, optimize patient outcomes has made the field more appealing to future trainees, and I expect and I hope that it continues to grow. So I wanted to ask you one more question, and then we're going to get to a kind of a rapid fire where we ask you quick questions with quick responses. But one of the things that I was interested to hear about, to tell the audience, and we asked all of our guests, if you had to look back on your career, your life, and you could say, you know what, I really regret doing this, and I wish that I could impart or tell somebody else, this was my regret. Hopefully this will allow you to not make the same mistake. An example that somebody else gave on one of our recordings was this reconstructive microsurgeon was at the beach with their family, and the whole time they were at the beach, they were on the phone with a work call and not really paying attention to their family. What would you say would be, looking back on your career, any regret or anything you could help teach us?
I think for the career itself, I like to say all my, the great is minor. For example, I spend more time and more stressful. I earn less money. This is something. So this is something to great, right? and however, the other things the rest of the things are really, enjoyable to myself. And I like to make a few, comment before you brought it up. One is that the young surgeon should be enthusiastic.
Yes.
And the system in the future eventually will change. But at this time, it not come yet. Like they pay you less. And then you better, continue to do it because you really enjoy it. You really feel that you do something that the other people cannot do, or some people may not like to do. Okay. So this is something I like to. And the second one is that I like the young people remain humble. They like to read more, and they like to see more, and they like to talk more to those people that they have the experience. Otherwise, now I have many visitors. That, for example, like this week, I have at least 6-7 visitors besides the fellow.
Wow.
And when they ask the question, you may notice that although they were trained, they're not trained well, and so this is something that you may not expect that you can learn all from your own center. So you may have to travel. And then the other thing is that now people like to use the terminology of so-called innovation, and everyone emphasizes innovation. But in my opinion, innovation, someone who is qualified to innovate is that someone who already know, better than the other people. Otherwise, if you only learn functioning muscle, you only do 3 cases, and then you now, the 4th case, you change it a little bit, and then you call innovation.
Yep.
And you're not able to. So innovation should be very carefully. Don't, always exaggerate. And the last one is that microsurgery it's a science. I like to say science. It's not only the technique. So I don't like one of the slogan from a company who say, this is the ultimate solution for microsurgery. And it's only for microanastomosis, not for the others. So this very often from my fellow when they first come, still have this. And visitors, many, they feel, this is interesting. And I tell them how to do the planning. And I also tell them how to do the recording, the record, the medical record. I haven't mentioned. For example, like now I have about 4,000 cases, more than 4,000 cases of microsurgery myself. I like to say I have about 80% to 90%. They have a complete set of pictures.
Wow, that's amazing.
Wow.
Like the pre-op, intra-op, and post-op.
Yes.
And every post-op, they follow up. So for example, when you say, Fu-Chan, how many cases of mandible reconstruction that you have performed, and in this case with immediate osteodegrading teeth. Then when I put the key in, the keyword, it come out 150 cases, and all patients' information and all the picture are there.
It's amazing.
Wow.
And I'm almost illiterate to the new technologies, 3D technology, but I was able to come up with this. In the earlier days, I took it and I filed, and then I have a paper, and then later on I converted into electronic, and now it's very convenient, especially when you have the iPhone.
Yes.
The pictures, the quality is good enough.
It's amazing, yeah.
Yeah, so this is something I really like to suggest to the young generation.
No, that's great. And so our last segment is some quick questions and quick answers. We call it the rapid fire section. And so Hank and I will ask you a few, but what is your favorite surgical instrument? And do you listen to music in the OR? And if you do listen to music, what kind of music is it?
Because our OR, the nurses are very, very, like to say, they're relatively young, and they are very willing to help. You won't see the nurses like ours, that they always smile. But sometimes, of course, when they smile, they may make a noise.
Yeah,
it's better that you learn not to be bothered by that, and because that they will help you until the very end.
Mm-hmm.
So this is important. And the music, basically, I like classic music.
Yes.
And classic music calm you down. So when your mind is calm, you don't make a major mistake. If you can think about if you struggle with something, and there's a very hot music,
that's not helpful. Yeah,
sounds like a push, and then you're very bad. So I like to stop the music, and I don't like song, because song I may like to listen to what do you think. This just the melody is very good.
Absolutely.
So I like this.
And then what about favorite surgical instrument?
There's no special instrument. I just use the ordinary one, and to make sure that they're well maintained, especially the microforceps and Caesar, and those micro instruments should be well, protected. If you have anything damaged, then that may increase the complexity of your surgery.
Absolutely. I could not agree more. Absolutely.
Yeah. And if you weren't a microsurgeon or if you weren't a surgeon, what would you be? If you could be anything else?
I cannot change anymore. I like to go out and to have my private cosmetic clinic so that I can earn more money, and spend more time with my wife. No, I'm just kidding.
Yeah.
You know, I have
that sounds pretty good, actually.
Yeah.
I think if you're able to give someone feel that they have achieved something, fulfilling something, maybe that is the way to keep someone, the lifelong, and it's too late for me to change.
Yeah. Do you drink tea or coffee before a long surgery?
Yeah, I don't mind. Any time. It doesn't bother me. It doesn't increase the tremor. I still remember in my time, the earlier days, no this.
Yeah.
So I don't basically. And even now in America, still, when the patient, the scheduled patient, they are smoking, and you may advise them not to smoke, right? But did you check that they really quit smoke before surgery? The answer is no. It's no. I still remember in the earlier days, I met my friend in Germany. The German way is the surgeons are very authoritative, right? And I asked him, if the patient did not follow your order, continue to smoke, what would you do? In my earlier days. And I asked him about this. And he was very proud to say to me, then I don't do surgery for them. And now I realize this may not possible. Yeah. So but you have to advise as a physician. But when they continue, I think you better say that the complication rate will be higher and the failure rate will be higher. That is more in reality.
Yeah. My last question for you, and thank you again. This has been such an incredible experience, someone in my position to be able to learn from you. And I think our audience is going to just find this so incredible, and they're going to learn so much from your wisdom. My last question, just on a lighter note, is what do you like to do for fun outside of work?
When I was young, I enjoyed playing golf, and I enjoy many other things, reading and many other things. But when I, start my career as a microsurgery, and because the time limitation, and I quit play golf because Sunday is the only days that I can sleep late. So, and my wife doesn't like to have too much sunshine. So then if I go there, I will leave her alone in the home. So I always try to do the so-called family. Like, of course, the kids are all grown up. They left us, but the goal with wife to do something like a small walking, like to enjoy some good food and enjoy seeing something beautiful. And this is my leisure life. I don't have any particular, and I lost them. Mm-hmm. When I was young, I did have many favorite sport or other things, hobby, but now it's a compromise.
No, absolutely. Well, thank you so much for joining us tonight. It was really special to get this one-on-one time with you.
Thank you very much for giving me this opportunity to speak something that I didn't have the opportunity to share. But I do really like to share. It's somewhat fun. Thank you very much. Thank you.
Absolutely.
Thank you.
Thank you. Good night.
Thank you for listening to The Deep End, a plastic surgery podcast. If you've enjoyed today's conversation, please like, subscribe, and leave a rating on Apple Music or Spotify. Video from the podcast is available on Instagram and YouTube at the Deep End Podcast. Join us again soon for more conversations with luminaries and experts in the world of surgery.